Hey everyone, it's Sarah with RegisteredNurseRN.com, and in this video I'm going to be doing an NCLEX review over kidney stones, also called renal calculi. And this video is part of an NCLEX review series over the renal system. And don't forget to take the free quiz at the end of this video. So let's get started. First, let's start out talking about what are kidney stones. Kidney stones are hard, insoluble, crystallized minerals and salts that have formed out of the filtrate produced by the nephron. And we learned in our video about nephron structure and function that your nephron, which your kidney contains millions of those, takes your blood, filters it, removes minerals and salts and waste from the blood, and then takes it through the tubule part of the nephron, where parts of that filtrate is going to be reabsorbed, secreted, or excreted as urine. And what's happened with kidney stones is that some of those materials or minerals that are removed from the blood, there's a high concentration in the filtrate, and these minerals and salts start to come together, they form crystals, and then turn into hard stones, which we call kidney stones. Now let's talk about some facts about kidney stones. Kidney stones can vary in size. They can be super small, like a fine grain of salt, or large, like let's say a walnut. And these stones can be composed of various types of materials. And there's 5 different types of kidney stones. Now, as we go over this, try to remember what is causing this and what it's really made up of, the stone specifically, because a physician's treatment plan is going to depend on what type of stone the patient has, which will include your nursing interventions and your diet teaching. So the most common type of kidney stone is called a calcium oxalate stone. And this tends to form in acidic urine due to increased amounts of calcium and oxalates in the urine. So what's happened is that your nephron has filtered your blood and it has removed a lot of calcium or a lot of oxalates. And those minerals have went through the renal tubule and they've started to bind. They've started to crystallize to one another. And as they've done that, they start to grow. Debris can stick to them. They can harden and turn into a kidney stone. So what causes increased concentration of calcium in the urine? Well, any condition that really causes hypercalcemia. And we talked about this in our fluid and electrolyte series. And taking a lot of medications like calcium supplements with vitamin D can increase calcium levels. Also, hyperparathyroidism, which we also talked about in our endocrine series, because remember, your parathyroid gland releases parathyroid hormone, which causes your bones to release calcium into the bloodstream. So if you're releasing too much calcium in the bloodstream, you can develop too much calcium in the urine. Also, increased intake of sodium. When a person consumes a lot of sodium and it's filtered into the urine, what happens is that sodium prevents calcium from being reabsorbed back into the bloodstream. So you're left with all this calcium in that nephron, which makes beautiful conditions for crystallization with other minerals to form a kidney stone. Now, what causes increased oxalates? One thing that can cause this is called GI disorders. And a lot of GI disorders, like ulcerative colitis, they have issues really with absorbing fats. And what can happen, normally our body takes calcium and oxalates and binds them together in the gut. And then oxalates are secreted out through the stool. So we're keeping this fine balance of oxalates in our body because we don't want too much to build up in the urine. But what happens with these GI disorders is that these fats are not digested. So instead of calcium binding with the oxalate in the gut, it's going to run to the fats and bind to that. So you have fats and calcium binding, and that just leaves oxalates all by itself. And this leads to excessive oxalates in the body, which in turn in the urine, and you can develop calcium oxalate kidney stones because all that concentration of the oxalates in the urine is going to bind with calcium and you get a stone. Another thing is high intake of foods that contain oxalates, which we'll be discussing later in our diet teaching. Another type of kidney stone is called a uric acid kidney stone, and this forms when there is too much uric acid in the urine. So the pH of the urine is acidic, it's very low. And remember, whenever we talked about in the nephron function and structure video, we talked about how the glomerulus takes the blood and filters it. And one of the things it filters is uric acid, which is like a waste product from the breakdown of proteins and things like that. Well, what can happen is that too much uric acid can be in the body, so it's going to collect in Bowman's capsule, go down through those renal tubules, and it's going to start crystallizing with each other, and you're going to get a kidney stone. Now, what can cause this? What can cause increased uric acid levels? People who have gout, people who are dehydrated. When you're dehydrated, you have low amounts of water in your filtrate, and it becomes concentrated, it becomes acidic, so you have this high probability of forming uric acid crystals within the filtrate. Metabolic issues like diabetes, specifically diabetes type 2, high intake of purine foods or animal proteins, because this, whenever the body breaks these down, it breaks it down into uric acid. So if you're consuming a lot of these, you're going to be breaking it down and producing a lot of uric acid to the urine. Another type of kidney stone is called cystine kidney stone, and these are rare. They tend to be genetic, and they form when there's too much of the amino acid called cysteine in the urine. So what is happening is that whenever your nephron, specifically glomerulus, is filtering that blood, remember it filters amino acids, goes down through Bowman's capsule, down through that proximal convoluted tubule. And remember here, this is where most of our reabsorption occurs of that filtrate. And the PCT is usually responsible for reabsorbing 100% of those amino acids. However, this is not what is happening in this condition. It's leaving these amino acids, and these amino acids are forming together, crystallizing, which in the end can turn into a kidney stone. Another type of kidney stone is called a struvite kidney stone, and these are rare just like the cysteine type, and they form in patients who suffer from chronic urinary tract infections. And what can happen is that this bacteria that keeps causing this urinary tract infection changes the pH of the urine. It increases it to make it more alkaline. So kidney stones can form in both acidic urine, like with your uric acid stones or your calcium oxalate stones, and alkaline. So one is not better than the other. So patients have a susceptibility depending on whatever their urine pH is. And these stones tend to be composed of magnesium, ammonium, and phosphate. And the last type of stone a patient can have is called a calcium phosphate stone, and this tends to form in alkaline urine as well. And a lot of patients who have issues with the renal tubules, the part of the nephron, have issues with these type of stones called the calcium phosphate stones. Now, where do most of these kidney stones tend to form? They tend to form in the kidney, but they can form anywhere, wherever there's a high concentration of those minerals and salts. And once the stone forms or the crystallization forms, it can start to migrate throughout the urinary system, where it will further grow or it can get stuck, which can cause a blockage. Now, where can kidney stones be found? They can be found in the kidneys, specifically the calyx, and the calyx is located up where the renal papilla is, and this is where parts of the nephron connect to the renal papilla and release the filtrate, which is urine, and it goes down into the calyx. So you can have a stone there. You can also have a stone in the renal pelvis, and you can have it in the ureters, specifically in the top of the ureter, in the middle part, or the bottom. And you can also have stones in the bladder, somewhere within the bladder, or the neck of the bladder. And most stones can be passed. So a lot of times your patient will be admitted, you'll be giving them lots of fluids and lots of pain medication, because if the stone is less than 5 millimeters, they can typically pass it. However, this is very, very painful. It's one of the most painful things a person can go through other than childbirth. And if the stone is larger than 5 millimeters and it can't be passed, the patient may need to go for some type of procedure which can help break up the stone, then they can pass it, or some type of surgical treatment, which we're really going to talk about a little bit later in this lecture. Now let's take a closer look and see exactly how a kidney stone could be formed. Okay, so first we really need the patient to have those predisposing factors, like too much uric acid in the blood, or they consume way too much sodium, which causes calcium within the nephron not to be reabsorbed. So you have a concentration of minerals and salts. So we have that. Then what happens is that these concentration of minerals form a crystal. And the crystal, they start sticking together, it can grow, debris can form around it, make it even harder, and you get a kidney stone. Now let's look at how this crystallization can happen within the kidney, specifically the nephron. So in your kidney, you have millions of these nephrons, which is the functional unit of the kidney that filters the blood and produces urine. Now, if you took one little individual nephron and stretched it out, it would look something like this. You have your glomerulus, which is taking your blood and filtering it, and it's making this filtrate, which is a liquid substance that contains minerals and ions, all these things. So in here, we have calcium, sodium, amino acids, glucose, oxalates, everything you can really think of, except proteins and blood cells. That is not filtered. And here we have a patient who has really taken in a lot of sodium. And what's happened is that everything's collected into Bowman's capsule, then it's went down through the renal tubule. And the renal tubule is where reabsorption, secretion is going to happen. So this patient specifically has a lot of sodium. So what has happened is that the calcium cannot be reabsorbed into the bloodstream. So it just hangs out in the system. So you have a lot of calcium and you have oxalates present in there. So what's going to happen is that your calcium and your oxalates are going to stick together and form crystals, and then you're going to get kidney stones. So as that's traveling through your nephron, it's going to come out of parts of your kidneys because your collecting duct connects to the renal papilla, which is going to release the filtrate down through your minor calyx, your major calyx, then your renal pelvis, and out through your ureters. Well, what can happen, many things can happen, but one thing that can happen is that that crystal can stick in that renal papilla or another duct, and it can just grow over time and become big and stay there, or it can break off and travel down to the ureter and completely block it, and you get backflow of urine or things like that. Now let's look at the causes of a kidney stone. We talked about this a little bit whenever we went over the 5 different types of kidney stones, but let's look at it a little bit further, because for testing purposes, a lot of times tests like to ask you which patient is at most risk for a kidney stone, and you have to select. So to help us remember that, let's remember the word crystal, because we have crystals being formed in our urine. So this will help us remember the causes. Okay, C, for consuming foods high with oxalates, purine, salt, or medications with calcium. And this puts the patient at risk for calcium oxalate stones and uric acid stones. R, for recurrent urinary tract infections, and again, that was with the struvite stones. Y, we have a couple Y's, hypercalcemia or hypercaluria, where you have too much calcium in the blood or in the urine. This can lead to that. Or hyperparathyroidism, and this is where, again, your parathyroid gland is responsible for stimulating those bones to release calcium into the bloodstream. So if you're doing that too much, you can get too much calcium. And another condition called hypocitraturia. And this is where you have low amounts of citrate in the urine. And citrate is actually helpful in preventing kidney stones, some types of kidney stones. And citrate will prevent calcium salt formation. So it will prevent those calcium salts from actually binding together. And it helps keep your urine alkaline, which will help prevent those uric acid stones and the calcium oxalate stones, which like to form in that acidic type urine condition. S for structural blockage or stasis of the urine. This can happen with patients who have prostate problems. Remember, with an enlarged prostate, it squeezes the urethra shut so urine cannot get out. Whenever they try to void, they'll have a lot of urinary retention, which keeps the urine within the bladder, which will allow those minerals to just stick together and be concentrated together, which increases the chances of a crystal forming. Also, other things which can cause the same thing are like strictures or deformities. T for too much uric acid. This is in conditions like gout, becoming dehydrated, consuming a diet high in purines, or animal proteins, because remember that is the byproduct. They break it down into uric acid when you consume those foods. A for absorption problems. Again, like we said, your gastrointestinal issues like with ulcerative colitis or Crohn's, where the fats are binding with the calcium in the gut instead of the calcium binding with the oxalates, and that would cause oxalates to be excreted, but instead the fats and the calcium bind, and that leaves the oxalates, and the oxalates will collect in the urine, and you can get calcium oxalate stones. And then another A for acquired. A lot of times if mom, dad, grandparents had a lot of recurrent kidney stones, you're at risk for it as well, especially with the genetic type, with the cysteine stones, with the high amount of the amino acid cysteine stuck in the urine. L, the last part, low activity, and these are your patients who are immobile. So try to remember immobility, because what's happening? Why are these patients at risk for kidney stones? Well, when you're immobile, you're not walking, you're not moving, you're not using all those minerals that you normally should if you're physically active. So, but you're eating and you're consuming food, so you tend to have a high amount of minerals in your body. Plus, the urine stays stagnant. They're not up moving. They're typically lying in the bed. The only type of mobility they get is when someone comes and turns them. So that keeps the urine stagnant, which can increase the ability of those minerals and salts to come together and form a crystal. Now let's look at the typical signs and symptoms that your patient may report who has a kidney stone. Okay, the first thing is pain. This pain can be very, very intense. And the description of the pain varies depending on the stone's location. So remember, for testing purposes, these different types of pain, because test questions like to ask you about, this patient says that they're having this type of pain, where could the kidney stone be located? Okay, so a type of pain they can have is called renal colic. And this is where the stone is probably located in the renal pelvis, which is this part in here. And they will describe it as a deep, dull, aching pain in the flank, which are the sides, or the costovertebral area, which is on the back. Now, a different type of pain they can have is ureteral colic, and this is where the stone is probably located in the ureter, and as it moves through that ureter, it can cause some very, very intense pain. They will describe it as intense, sharp, it's wave-like, and it radiates, and in men it can radiate to the scrotum, and in females it can radiate to the vaginal area. Now, as the stone moves, it's going to scrape up against that ureter, so you'll probably see some hematuria, blood in the urine, and they may say, I really need to void, but whenever they void, just a small amount comes out because that stone is blocking that ureter. Now, they may also have nausea and vomiting. This can be due to that intense pain they are in. It's literally making them sick. They can also have signs and symptoms of a urinary tract infection because a lot of times these stones can cause blockages, which is keeping that urine stagnant, and this can lead to infection because we learned in our urinary tract infection video that anytime urine is staying stagnant for a long period of time, we have a high risk of infection, which could represent a fever or cloudy urine. Another thing they can have is urinary retention, where they're voiding but they're not getting rid of all that urine out of the bladder. And this is especially if that stone is in the neck of the bladder, which is that area right before it enters into the urethra. So if that stone's there, it may prevent urine from actually draining completely out of the bladder, which increases the risk even more for urinary tract infections. Now, sometimes patients will be asymptomatic. They won't have signs and symptoms until the stone gets large enough or it breaks off and starts moving throughout that urinary system. Then they will start to notice those signs and symptoms. Now let's look at some complications associated with a kidney stone. A complication is called obstruction. Whenever you have that kidney stone obstructing urine flow, you have backflow of urine. And this increases hydrostatic pressure, fancy word for water pressure. Hydro means water, so you have increased water pressure within that kidney. What is that going to do? That is going to put a lot of strain on those nephrons, specifically that Bowman's capsule, and it's going to decrease the kidney's ability to actually filter that blood. So you're going to have decreased filtration. Another complication is called hydronephrosis or hydroureter-nephrosis. And what is happening with these conditions is that you have, say, a kidney stone stuck in the ureter. It is letting absolutely no urine, which is represented in this orange part, drain down through the kidney. So this urine is just backing up into the kidney. And what's going to happen when this happens over a long period of time? You can have different stages of this. What's going to happen in the most severe cases is that you're going to get dilation of your renal pelvis. So it's not going to be small like this. It's going to be really dilated. You're going to get dilation of those minor and major calexes, which are in here. And you're going to get dilation of your ureter depending on where that stone is. So you're going to really lose that functional ability of the kidney. Another thing, of course, is the nephron damage. And they can also develop the infection, which is what we really talked about in our signs and symptoms. Now let's look at how kidney stones are diagnosed, because as a nurse, you want to be familiar with what the physician may order or what your role is as a nurse whenever you're sending a patient for this test. Okay, one type of test is called a KUB, and this is an x-ray of the kidneys, ureters, and bladder, hence why it's called a KUB. Another type of test is called an IVP, and this is an intravenous pyelogram. And what they will do is that they will give your patient through their IV a special dye, which is iodine based. And it'll go through the system, and then they'll take x-rays of the urinary system. Now, your role as a nurse is important because before you send the patient for this test, you want to assess some things. You want to ask them if they're allergic to anything, and if so, what? Specifically, you're looking for iodine and shellfish. Are they pregnant, or is there any way they could be pregnant? Are they nursing a baby? And you need to look at their labs, see if they have impaired renal function. And are they taking metformin, also called glucophage? And if they are, you need to contact the physician. Another type of test they'll go for, possibly, is an ultrasound or a CT scan of the kidneys. And a physician may order urine tests, like a urinalysis, which will assess that urine for any crystals. And sometimes they will order what's called a 24-hour urine. And this is where it's going to measure the concentration of ions, which is like your calcium, your sodium, all those, the waste, uric acid, creatinine, the pH of the urine, the citrate level, and the kidney function. Now, as your role as a nurse, you want to make sure that this is being collected correctly, because if not, it can throw off the whole test result. So one thing you want to keep in mind is that you want to keep this specimen on ice Typically in the hospital setting, what I do is comes in the jug. They get a jug. It's usually like an orange jug. You'll put the patient's name on it, and you will have the patient, say you're going to start it at 8 o'clock that morning. You'll have the patient void in the commode, flush it down at that time and write down the time. Then from there on, the patient will void in that jug, and every time they have to pee, they will pee in this jug for 24 hours. Then at 8 o'clock that next morning, which is 24 hours, have the patient attempt to void again, then send it down to the lab. Now it's important that you keep the specimen on ice or refrigerated. Typically we keep it on ice because we don't use a refrigerator because of contamination, things like that. And we put it in a basin full of ice, like an ice bath, and keep it cold, because if you don't keep it cold, you can alter the results. Now let's look at nursing interventions and treatment for kidney stones and what your role will be. Okay, most patients will pass the kidney stone if it's, remember, less than about 5 millimeters. However, as a nurse, your role, you're going to have to help them with this, because this is not an easy task on the patient's part. They're going to have a lot of pain. So number one of our priorities is we're going to control their pain. The pain doesn't go away until it's passed or removed. So it's best to do around-the-clock pain medication administration, whatever your physician orders, instead of the PRN medications where the patient has to ask for it every time, because we want to keep those blood levels constant and we don't want their pain to get so bad where it really can't be controlled. So around the clock is best. Sometimes physicians like to order NSAIDs because this will help with the inflammation, because a lot of times when that stone is in there, it's scraped up against some of the lining, it's inflamed it, which is making the ability of that stone to pass through that area even harder. So the NSAID will decrease that inflammation, help that stone pass. Another thing just as equally as important is that we want to maintain fluids. We want to be telling the patient, you need to be consuming lots of fluids and bringing them water to drink, at least 3 to 4 liters per day, unless it's contraindicated if the patient has heart failure or something like that where they can't take in this amount of fluids. And it's whatever the physician orders, always follow that. Now, why are we going to be wanting them to consume this amount of fluid? Well, number one, it's going to keep that urine diluted. We don't want the urine to get concentrated, because if it does, there's an increased risk of another stone forming, so it dilutes the urine. Another thing is it creates this pressure of allowing urine to keep flushing through the system, which is going to help that stone to pass, and it decreases chances of infection, because we're flushing that system out constantly, which is a risk with kidney stones. Now, because we're going to be encouraging so much fluid, we have to very, very closely watch their intake and output, so eyes and nose. And we want to make sure that they're not taking in so much where they're very little putting out, because this could be a sign that there's an obstruction where that kidney is not draining properly, which can lead to hydronephrosis and things like that. So watch those eyes and O's very closely. Another thing is that we're going to be monitoring the patient for urinary tract infections, because they're at risk for that. And another super important thing is that we want to collect all their urine. Normally we have these little white hats that they can pee in, or a urinal for men, and you will take that urine and you'll strain it in this strainer that you can get from Supply, and you're looking in that strainer for any stones, and you do not want to throw that stone away. You want to keep it, put it in a cup. Many physicians already have a standing order to go ahead and send that to the lab, or get an order to send it to the lab, because they want to figure out what that stone is composed of, because that will depend on the treatment plan. They'll know why they're getting these stones. So always do that. And another thing is to keep the patient as mobile as possible, because we want them to be moving. And if your patient is immobile, you want to turn them frequently. Why is that important? Why do we want to do that? Well, moving around up is going to help that stone move. Also, we don't want them just to lay there in the supine position in pain because it's keeping that urine stagnant in those kidneys, which can increase the risk of another one forming and the stone not passing because you're just laying there. So try to keep them as mobile as possible and let them know why we want them up moving. Now let's talk about patient education, because these stones can reoccur and you want to let them know how they can decrease their chances of this happening. One thing is that they need to stay hydrated. It's very important they do not become dehydrated whenever they're at risk for this, because concentrated urine can produce stones. So they need to drink at least 2 liters per day unless they have contraindications. They need to, if the physician prescribes medications, because sometimes the physician will prescribe, for instance, allopurinol, which helps decrease uric acid levels. If you've ever had a patient have gout, they will be on this. So tell them why they're taking this and what it's for. Another thing, if they're at risk or having those kidney stones that are made out of calcium, they may be started on hydrochlorothiazide, which is also called HCTZ, and this is a diuretic. It works on those tubules within the nephron, and it helps decrease the amount of calcium in the urine. Next, you will want to educate them about not taking as many supplements that are calcium based. You need to assess, are you taking a lot of calcium supplements with vitamin D, because this can increase the risk of calcium stones. Another thing is that limiting calcium in the diet is really not recommended unless the patient has a metabolic problem, because the risk of osteoporosis and things like that. So that's really not recommended. Only if they have metabolic issues where they would need to have that. Another thing is limiting protein, because remember, protein breaks down into uric acid. It can also increase calcium levels. So watching the amount of animal proteins that they're consuming. And limiting foods high in sodium, because what did sodium do? Whenever you have a lot of sodium in the urine, it prevents calcium from being reabsorbed. So we have an increased chance of calcium stones being formed. So they need to consume between 2 to 3 grams of sodium a day if they're having those type of stones. Another thing is consuming a diet low in purines, organ meats, beer, pork, red meats, seafood like scallops, anchovies, sardines, and remember again, this can form those uric acid stones. And also consuming a low diet in oxalates. If they were producing those calcium oxalate stones, they would want to avoid consuming high amounts of like spinach, cabbage, rhubarb, tomatoes, beets, nuts, and chocolate, along with wheat bran, strawberries, and tea. Now let's look at the treatment options for someone who has a kidney stone. Maybe you're taking care of someone who has a stone that cannot be passed, so they need treatment, where either the urologist is going to have to remove it or they're going to have to break up the stone. So let's talk about these different types of treatments and what your role is as the nurse who will be receiving a patient back from one of these procedures. Okay, one type of procedure is called an extracorporeal shockwave lithotripsy, also called ESWL, and this is non-invasive, so they're not going to have any incisions or anything like that. And what this is that ultrasound shock waves are sent through the skin and body tissue to break up the stone into fragments. So what happens is that these ultrasound shock waves are sent. Hopefully it'll break up that stone into smaller pieces that can then easily pass through those ureters. However, this is not for large stones, and sometimes patients require multiple treatments of this therapy. Sometimes a stent may be placed to allow the stone fragments to pass through, and one of the downsides about this procedure is that the patient will have to pass these fragments and these stones, so it's going to be painful. Now, our role as the nurse, whenever you get a patient back from this, very important, you're going to strain all of that urine and send that stone to the lab so they know what type of stone this patient is experiencing. You're going to maintain fluid intake between 3 to 4 liters because we want to flush that system out to help guide those fragments out of the system. We want to keep the patient as mobile as possible so it can help facilitate the removal of those fragments and control their pain, because again, they're going to be passing these. And because they will be passing these fragments, there may be some blood in the urine, so watch out for that. Another type of procedure is called a percutaneous nephrolithotomy, and this is an invasive procedure. So it's different from ESWL, which was non-invasive. This patient here is going to have an incision, and what's going to happen is that the urologist is going to go in and remove the stone. So the upside is that they most likely will not be having to pass the stone as they did in the other procedure. So an incision will be made on the back where the kidney is located, and a nephroscope will be used to remove the stone. Sometimes they can use the lithotripsy to break up the stone and get those fragments. So what will be your role as the nurse? Many times after this procedure, a patient will have a nephrostomy tube placed. What is a nephrostomy tube? This is like a small little tube that is placed within the kidney, specifically in that renal pelvis area, that will help drain that urine that's freshly coming out of those nephrons. And it will also drain some of the fragments that have been left over maybe from that stone removal. So you'll want to keep the nephrostomy tube secure, make sure it doesn't move, monitor for infection because we're at risk for infection. And you'll want to empty and strain the urine that comes from the nephrostomy bag. So the patient will have a bag, a little bag that will be hanging down, and a tube that will be coming out of the side, out of the back. Also, you'll want to maintain 3 to 4 liters per day, keeping them hydrated, keeping that urine flowing out to flush out any possible fragments. Another procedure a patient may have to remove a kidney stone is called a ureteroscopy, and this is where no incision will be made. Instead, a scope will be inserted up through the urethra and can go all the way to the kidney, and what they'll do is assess for stones. They can go and remove the stone. They can do this either with a laser or with a lithotripsy, and many times a stent will be placed to allow those fragments that are left over to be removed. So you'll be doing the same nursing interventions with maintaining the fluid, 3 to 4 liters, keeping them mobile, straining the urine, sending that stone to the lab whenever you collect one. Okay, so that wraps up this lecture on kidney stones. Thank you so much for watching. Don't forget to take the free quiz and to subscribe to our channel for more videos.